October is Breast Cancer Month, and as a plastic and reconstructive surgeon, it's very important for us to work very closely with the oncologic surgeon. Today, we have a guest at the clinic, Dr. Houriya. We've known each other for...
Well, we worked together for about 17 years.
Known each other forever. We've worked with each other for 17 years. Mm-hmm. And we've worked very closely with each other. And Dr. Houriya is a breast cancer surgeon.
Yes.
And so tell us a little bit about breast cancer in Dubai.
Well, first of all, breast cancer is one of the most common cancers in women in the UAE. So pretty much everyone knows someone who's had breast cancer. Worldwide, the numbers for breast cancer are increasing, unfortunately. But at the same time, the fatality rate, or the number of people dying from breast cancer, has really gone down. And a lot of that is because, and a lot of that is partially because of screening. Women who are fine, who go and have their breasts screened for cancer, even when they don't feel anything. And partially the death rate is down due to better treatment of breast cancer. So from a surgery point of view, the first thing I'd like to say is not everyone who has cancer has to lose their breast. We can do a lumpectomy for many women. That means just removing the cancer and saving the breast. Unfortunately, sometimes we do have to remove the breast. That could be in cases where the lump is big in relation to the size of the breast, or if there's more than one tumor in the same breast, or if the tumor is quite close to the nipple, or if the patient has a genetic predisposition that they've inherited from their family that made them likely to get this cancer, then their risk of another cancer could be high. So we actually would remove both breasts, not just one. And sometimes it's patient's choice. Patients tell me for their sort of psychological well-being, they feel better if they know that the breast is gone.
So removing a breast is called a mastectomy.
Yes.
So what are the different types of mastectomies?
So, well, it used to be up until sort of probably the late 90s, everybody who had a mastectomy basically went flat. That was the only option. We remove the breast, we remove the skin of the breast, we remove the nipple areola complex, and we go right down to the chest wall, and you have a scar right across your chest, and that's the mastectomy that we offered everyone up until the late 90s. And then some very brave surgeons thought, well, why are we taking off this much tissue for a small tumor that's deep in the breast? So they started trying to save the skin. They would still take the nipple because most breast cancers actually start in the milk ducts, and all the milk ducts converge on the nipple. So the thinking was, we'll take the nipple, but we'll try to save as much skin as possible. And then somebody like yourself would fill that gap under the skin with something to resemble a breast. And then as time went, and they realized, well, you know what? The recurrence rate was not higher that people were worried about by saving the breast. So let's try and save the nipple. So now we save the skin, we save the nipple. Literally, we save everything. So when you look down at yourself, or when a woman looks down at herself, she's had just the breast tissue removed. And then when it's reconstructed, it actually is her skin, her nipple, looks like what it looked before, and sometimes even better.
Yeah, I think that's the reassuring part, at least of the reconstructive surgery, right? Because when you have a mastectomy, it's a grieving process, isn't it? Like you're losing your breast, you're losing your nipple, and oftentimes, it's associated with one's femininity. Some people don't care, and some people it affects them a lot. Yes. When we do reconstructions, I think there are two big questions to ask. Number one, the timing of the reconstruction, meaning you can either do it at the same time as a mastectomy, so actually the woman wakes up with a breast,
yes,
or you can do it later. Mm-hmm. And similarly, the question then becomes is, okay, whether you do it now or later, what type of reconstruction? And to simplify it, we just divide it into either you use an implant, or you use your own tissues, either the back muscle or the tummy. Mm-hmm. Exactly. And I think with that, having said, okay, you have the mastectomy, you do the reconstruction, but we also work very closely with the chemotherapy, the person who does the chemotherapy, like the chemotherapy
Yes.
physician, the medical oncologist, the radiation oncologist.
Yes.
And that team becomes very important because you have to look at the patient as a whole.
Exactly. And every patient's different. So some patients will have chemotherapy first, either because it's an aggressive tumor or we're trying to shrink the tumor down to allow them to have less surgery. Some people will go straight to surgery. Some people will end up having radiation, which will have an effect, obviously, on what type of reconstruction you can do for them. So yes, we do. It is definitely a multidisciplinary approach to every patient, certainly in terms of their surgical treatment.
I know that when we have patients together, we've been working with each other for so long, I can actually already know what you're thinking and you already know what I'm
Yes.
thinking. So, when we see a patient that one of our mutual patients, I would call you and say, okay, so tell me, are we going to do radiation? Are we going to do this? And vice versa, you already know what type of reconstruction we're going to do. And I think that makes it very, I think that teamwork becomes very important when it comes to the diagnosis.
And I think it's important that we can offer patients that. I think many people still think of a mastectomy as, you're literally chopping the breasts off and that's it. And when I tell them that, look, actually we make little hidden scars, you still have your skin, you still have your nipple, just the inside bits are different, they're actually surprised. And I think it's great that we can offer that. There are still women who choose to go flat, who decide that they don't want a reconstruction. So it's not to say everyone has to have it. I think, like you said, every woman is different, and how she views her breasts, how she views her body is different from woman to woman. So I think this is where we spend a lot of time, talking to the patients, finding out what works for them. And then, maybe seeing them a few times to get their opinion on what they think is important, or what they can live with in the long run.
Yeah. I feel like this topic there's so much depth in this topic, and every patient's journey is different. And I think we are both honored that we can be part of this journey with the patients.
Yeah, it is quite a journey.